Hello, my name is Yvonne Creighton. I am a candidate for the Doctor of Nursing Practice degree here at Maryville University of St. Louis. Today I'm going to present my DNP scholarly project, Reducing Consequences of Problematic Alcohol and Drug Use. Many thanks to Dr. Rita Wunderlich, DNP Chair Extraordinaire. Her insights and feedback have been invaluable to me. Thank you also to Dr. Deborah Lee. She provided guidance on the knowledge assessment tool and lent her expertise on motivational interviewing, as well as reading the manuscript. Misuse and abuse of alcohol and drugs is a healthcare burden in the United States. The Substance Abuse and Mental Health Services Administration, SAMHSA, recommends the evidence-based intervention screening, brief intervention, and referral to treatment, or SBIRT, to help reduce risky and problematic drug and alcohol use. SBIRT has been shown to reduce the negative consequences of problematic and risky alcohol use, which includes higher healthcare costs and poorer outcomes. There is a need for providers trained to deliver evidence-based interventions like SBIRT to patients who use alcohol and drugs. Advanced Practice Registered Nurses, APRNs, are ideal providers for this job, as teaching and counseling are vital roles for the APRN. To implement SBIRT, they need education and training. Unfortunately, APRN programs do not universally include all three components of SBIRT, which are screening, intervention, and referral, in their curricula. Savage et al. In 2017 surveyed APRN programs in the United States to determine to what extent they included content on screening for alcohol and substance use in their core courses. Almost all of the 90 programs surveyed included screening for alcohol use, while little more than half included brief interventions or referral to treatment. 2/3 of the programs taught screening for drug use, while they taught intervention and referral to treatment only about 1/3 of the time. Based on the inconsistent implementation of all three components of SBIRT in the sampled APRN programs, the survey authors recommend the development and implementation of a national curriculum to deliver SBIRT content to all advanced practice nursing students. Implementation of an SBIRT training module in an APRN curriculum has significance for the entire profession of nursing, APRNs, and healthcare at large. The aim of this scholarly project was to increase APRN students' knowledge of SBIRT and improve their attitudes towards people who use alcohol and drugs. The literature review supports the inclusion of an SBIRT educational module in an APRN curriculum. The review revealed themes and concepts related to the research question, after the completion of an SBIRT educational module, will APRN students' knowledge of SBIRT increase, and will their attitudes towards patients who use alcohol or drugs improve? Additionally, the theme of SBIRT training being helpful, useful, and important emerged. The research articles were critically reviewed to reveal their overall strengths and weaknesses. Overwhelmingly, students reported improved confidence, competence, readiness, and improvement of screening and communication skills after SBIRT training. One of the goals of this project was to improve students' attitudes towards people who use alcohol or drugs. Half the research articles addressed this issue, and the results were mixed. Senrick et al. In 2017 compared attitudes of students who had received SBIRT training to a previous cohort who had not received training. Students who received training were found to have significantly higher positive attitude scores than students who had not received training. Pre- and post-SBIRT training assessment scores regarding attitudes did not change significantly in several studies of nursing, social work, and medical students, presumably because pre-assessment attitude scores were already high or positive to begin with. In 2 studies, undergraduate and graduate nursing students were less motivated to work with people who use alcohol or drugs after SBIRT training. Similarly, nursing, social work, and medical students remained skeptical that patients would change their behaviors if exposed to SBIRT. While the results were mixed regarding students' attitudes towards people who use alcohol or drugs, knowledge of SBIRT increased across the board. Undergraduate nursing students' core knowledge of standard drink amounts, screening, and the components of brief intervention improved after training. Knowledge increased in master's level nursing, social work, psychology, counseling, and medical students through both self-report and standardized competency assessments. SBIRT training increased knowledge of SBIRT, as well as motivational interviewing for counseling and psychology students. A fourth theme that emerged from the literature review was related to students' perception of SBIRT training as being helpful, useful, or important. Students who were asked reported that SBIRT training was useful, valuable, and relevant to their careers. In one case, the usefulness decreased significantly at 30 days, possibly because of the time lapse since training. Social work students who received SBIRT training and used it in their clinical placements reported that training was important and would benefit their clients. During integration of SBIRT training across the curriculum of one MSN program, it was found that students applied all three components in clinical practice, demonstrating the usefulness of SBIRT training. There appears to be a discrepancy between knowledge and self-efficacy that is gained through SBIRT and students' subsequent motivation to work with people who use substances. Although students' knowledge increased after training, in some cases, motivation to work with patients who used substances decreased, and skepticism that patients would change their behavior remained. This is an area that warrants further investigation, perhaps through qualitative inquiry, as the original goal of the DNP project was that students would believe that they have the ability to use their newly learned SBIRT knowledge in their practices. Belief is a concept that surfaced early in the development of this project. Several beliefs are essential to the success of implementing SBIRT in an APRN curriculum. First, the DNP student researcher needed to believe that implementing SBIRT was a worthwhile endeavor. Practicing APRNs must also believe that patients can reduce or eliminate substance use. Finally, and perhaps most importantly, is the belief that the patient must have that they will be able to achieve behavior change. It is not enough for the APRN to believe that the patient has the capability of reducing substance use. Patients must believe in themselves, because ultimately the patient is the one who will act on that belief. Because belief played a prominent role in all aspects of the project, self-efficacy was chosen as its conceptual framework. One of the original goals of this project was to increase APRN students' self-efficacy in implementing SBIRT, in addition to increasing their knowledge of SBIRT and improving their attitudes towards people who use alcohol and drugs. The scope of the project was scaled back to measurement of attitudes and knowledge. However, because self-efficacy comprises the theoretical framework of this project, a review of it was still warranted. Self-efficacy is defined as a person's belief in their ability to produce desired results by their own actions. Self-efficacy is a middle-range theory that was born from Dr. Albert Bandura's social cognitive theory. Bandura, a psychologist, believes that behavior is determined both by social influences and a person's own thought processes or cognition. Behavior, cognition, and personal and environmental influences all work together to determine a person's view of their own self-efficacy. Self-efficacy is a person's judgment of their capability to perform a certain action. Self-efficacy is not a personality trait like self-confidence or self-esteem. Rather, it is applied to specific situations. The project investigated the effect of an educational module on advanced practice registered nursing students' knowledge about substance abuse and the components of screening, brief intervention, and referral to treatment, and attitudes towards people who use substances. The project utilized a descriptive, quantitative design. A convenient sample of 27 student participants was obtained from a cohort of 200 APRN students enrolled at the chosen university in the southeast region of the United States. The project was not a component of any course and was not associated with the grade. Participants were 18 years of age or older, and all genders were included. The racial and ethnic background of the participants was assumed to be 85% Caucasian and 15% other ethnic groups, which approximates the background of the APRN students' population at the university. For their data to be included, they must have completed both pre- and post-knowledge assessment and attitude survey tools. The student participants completed the inclusion information questions upon accessing the Qualtrics link. Two data collection instruments, a knowledge assessment tool and an attitude survey, were used to garner information before and after students viewed an educational module. Student participants were asked to complete a knowledge pretest, an attitude survey, view an educational module, and take knowledge and attitude post-tests. The knowledge assessment tool contained 10 questions specifically related to the information presented in the educational module. The Short Understanding of Substance Abuse Scale, SUSS, is a 19-question survey that uses a 5-point Likert scale ranging from strongly disagree to strongly agree to assess a person's attitudes towards those who abuse substances. Inferential statistics can be used to draw conclusions about a population from a sample when the sample size is large enough. I planned to use inferential statistics to analyze the data. A one-tailed paired t-test is the appropriate test statistic when testing the hypothesis that there would be an improvement in attitudes and knowledge after viewing an expert educational module. Paired t-tests are used for dependent groups when the participants will be tested more than once using continuous data. A one-tailed test should be used as knowledge and attitudes are expected to improve after education, not worsen. Based on an effect size of 0.4, a significance set at 0.05, and a power of 0.8, the sample size needed to demonstrate power for this project was 41. 19 complete survey responses were collected for the knowledge pre- and post-tests. Descriptive statistics can be used when there's not enough data to run traditional comparison statistics. Because the sample was not large enough to demonstrate power, descriptive rather than inferential statistics were used for the knowledge test. Each respondent's average score on the knowledge pretest was compared to their average score on the knowledge post-test. The second set of data, the pre- and post-attitudes surveys, is a 19-question Likert scale. There were 16 sets of clean data collected for the attitude survey. The Wilcoxon signed rank test was run as an alternative to the paired t-test since there was not enough data to run the paired t-tests. This DNP scholarly project did not successfully change APRN students' attitudes towards people who use alcohol or other substances. Knowledge of SBIRT, however, improved after viewing the educational module. This project corroborated the literature that knowledge is easier to change than attitudes. The next two slides show the results in chart and table form. The average score of the 10-question knowledge pretest for the 19 complete sets of data was 5.58. The average score for the knowledge post-test was 8.47 out of 10, representing close to a 30% increase in knowledge scores after participants viewed the SBIRT educational module. 16 complete sets of data were retrieved for the Short Understanding of Substance Abuse Scale. Using Statistical Package for the Social Sciences, SPSS, software, a Wilcoxon signed ranks test was run to determine if there was a statistical difference between pre- and post-test scores. The test indicated that post-test ranks were statistically significantly different than pre-test ranks for just one question, with a z equaling negative 2.739 and a p of less than 0.006. Question 10 on the SUSS states, usually, if alcoholics and addicts fail to recover in AA, NA, or CA, or in treatment, it is because they are unmotivated and in denial. After viewing the expert educational module, respondents were more likely to change their answer from strongly disagree or disagree to neutral or agree. This reveals that after viewing the educational module, respondents were more likely to think that people with substance use disorders are unmotivated or in denial. Of note, question 10 on the SUSS is part of the eclectic subscale, which is the least reliable of the three subscales called disease, psychosocial, and eclectic, to assess attitudes. I spoke with a developer of this survey, Dr. Keith Humphreys, on the phone. He mentioned to me that some people leave the eclectic subscale off the survey because it was the least reliable, leaving 12 questions from the disease and psychosocial subscales. In hindsight, I probably should have done that, as 29 questions, which include the 10 knowledge and 19 attitude questions, are a lot of questions to answer 2 times before and after viewing the educational module. So less questions might have prevented some test fatigue. The sample size obtained was not sufficient to demonstrate power. N of 19 for the knowledge assessment and an N of 16 for attitudes survey. Because of this, the results are not generalizable to all APRN students. Increasing the sample size by inviting participants from multiple APRN programs across the United States could have strengthened the findings, allowed for more accurate statistical analysis, and improved generalizability. The design of the intervention was such that students had a limited amount of time to absorb, digest, and incorporate new knowledge into their clinical practices. The intervention, an educational module versus actual expert training, likely impacted the results as well. Had expert training and education been fully integrated in the APRN program, as Moore et al. Did during their curricular development, students' knowledge and attitudes may have improved significantly. It may have been presumptuous to believe that a time-limited intervention could impact ingrained attitudes towards people who use alcohol or drugs. A systematic review of stigma in substance abuse suggests structural level training and educational programs can be effective in reducing stigma. In addition to incorporating SBIRT into the MSN curriculum, anti-stigma training should be included in the curriculum as well. The project's pre- and post-test design is a common design in healthcare research. Pairing observations at different points in time, using the participant as their own control for the pretest, allows the researcher to compare the effect of an intervention after its implementation. It was expected that there would be an increase in knowledge and improvement of attitudes after viewing an SBIRT module. A 30% increase in SBIRT knowledge was observed on the post-test assessments. Had there been the required number of participants to achieve power, 41, this would have been a significant difference. Using the Wilcoxon signed ranks test to compare data that is not normally distributed, only one question on the attitude survey reached a level of significance. Respondents were more likely to respond that people who failed to recover from alcohol or drug abuse were unmotivated or in denial after they viewed the SBIRT educational module. Although the outcomes of this project mirror those found in previous studies on SBIRT education and training, Neither association nor causality can be inferred. Number of participants, length of intervention time, and anti-stigma interventions must be addressed to improve outcomes in the future. Attitudes are generally developed and ingrained through a person's upbringing and experiences. How a person feels and what they believe about people who use substances is not likely to change overnight, and certainly not after viewing a 20-minute PowerPoint and answering a few questions. Anti-stigma training and expert education, integrated throughout a master's curriculum, have the potential to change attitudes and ultimately improve outcomes for persons who use substances. This DNP scholarly project revealed the need for universal expert training and anti-stigma interventions in APRN programs. Expert training during school can lead to advanced practice nurses utilizing it in their practices. Future research ideas include adding anti-stigma interventions and expert training across the curriculum in an APRN program. Assessing students' knowledge and attitudes at baseline, after training, and during clinical rotations will allow time for knowledge absorption, hands-on practice in a clinical setting, and positive attitude changes. Following students after graduation who have been trained in expert can strengthen the association between training, attitude changes, and actual implementation in practice. All these things will lead to better outcomes for patients, which is the ultimate goal of advanced practice nursing research. Although the project did not have enough participants to demonstrate power, the results were similar to those from previous studies. It appears that knowledge is easier to change than attitudes. Because of this, I would be sure to include anti-stigma interventions along with expert training in the APRN program in the future. I originally envisioned assessing the effect of an educational module and expert training that would be housed in a health promotion course. Due to time constraints and realizing that was not an appropriate focus for a DNP project, the project changed from a lengthy training to an online educational module, which was a 20-minute PowerPoint, housed in a Qualtrics survey. Throughout this 2.5-year journey with Maryville University, from a postmaster's certificate in psychiatric mental health nurse practitioner all the way to DNP, I have learned a lot about myself, about statistics, and about the DNP process. I have learned that I have big ideas and need others to help me scale them back to be reasonable and doable. Thank you, Dr. Wunderlich. I have learned that I actually did need that statistics course that I tried to clap out of. Thank you, Dr. Pauls. And I have learned that practice improvement is the name of the game when it comes to advanced practice nursing. Research is wonderful, but practice is where it's at to improve people's lives. I appreciate all the lessons I've learned while in this program, and I'm so thankful for all the feedback and support I've had from my course instructors. The prospect of getting a DNP was daunting to me. However, the curriculum is set up so that you work on a chapter each semester and don't feel that it's all crammed together and rushed. It was not easy by any stretch of the imagination, but it was doable. And I'm glad it's almost done. This is a list of references used in this presentation. Here are some more, and here are the final references. For a full list of references, as well as the complete DNP paper, feel free to contact me at my Maryville University email address, which is ycreighton1@live.maryville.edu. Thank you for listening to my presentation.